Okay.
Stephen, how you doing?
Hold on. There we go.
How are you?
Let me see if I can. There.
You got it?
Yep.
All
I
right,
just
well,
switched my speaker output.
okay. I get a consistent backdrop now.
Oh, yeah.
So I
How you
have,
been?
so sorry, go ahead.
I said, how you been?
Blue. Busy. I'm busy. Friday, I will have like my 4th podcast interview.
Wow.
So same topic. And then I was invited to speak at my alma mater in the psych department to a colloquium up at Northern Michigan. So they're paying for my hotel. So
Are they getting you tickets to the hockey game?
it'll be April 15th, so hockey will be over. But
Oh, what a shame.
I know, but my wife is off that week for spring break, so we figured we might as well take the family up, and I've got family up there still. So
Yeah, well, April 15th, you ought to still be able to go ice fishing.
true. Yeah, I can't go in Lake Superior at that point yet. So
No, not at all.
yeah. So I was just gonna say I do have some other slides for I would talk about doing the questions first,
Okay.
like after the introduction and stuff.
You're gonna run those that little Q the 5 different questions I gave you.
Yeah, the 4. I think we had 4 questions. I think that we had
Okay.
on the thing. So yeah, we'll just run it and we'll let you talk about it, and then like I said, I'll do an introduction. And I'll briefly talk about. We always talk about like that it's on Indigenous land, so First Nations land. So we do a little bit of feel on that, and then I'll talk about like a little very briefly about my why I like wanted to do this series, and then I'll introduce you, and then we'll be good to go, and I'll start sharing my screen, and then you can just start.
Sounds good. After I met with Gerald this afternoon, I added just a couple more slides because, gee, there's always more material you could put in, and I'll talk real fast for some of it. We looked at the video. It runs pretty good. Sound was good. I'm going to cut it short because it'll take too much time.
Yeah.
And we need to be done in an hour?
Yeah, I would say, and then have a little bit of room for like Q&A.
Okay. All right, well, I'll talk fast. And then what I'll do is I'll send you the slide deck, which you can distribute whoever wants it. Okay.
Okay.
In fact, what I'll do is I'll turn it into a PDF and send it to you.
That sounds perfect to me. I'm just trying to get there it is. I'm sure you can hear my boys in the background.
I can.
So, yeah. I was just thinking, like, do I do it downstairs? But they would find me no matter where I am in the house. So
you're toast if you go downstairs.
Yeah. Yeah, and I'm just, like I said, just pulling up the introduction piece, and Bill, I want to introduce, and she just went off, but Angela Willis is our director for the part-time program, and
Yes. Hi, Angela.
has been a huge help in navigating this whole series. So
hi, Bill. I didn't realize I had my camera on earlier when I took a big bite of chicken, so I apologize for that. But
Looked really good, Angela.
so I'm coming from orthodontist and then middle school basketball game and now this, so squeezing in dinner. But thank you so much for being here. It's been such a pleasure to see this webinar series unfold, and Stephen has done such a great job, and can't wait to hear from you.
Yeah, I'm first of all, thank you for allowing me to participate. I really appreciate the opportunity. Any chance I get to talk about male factor infertility, and you got a huge registration for this. This is phenomenal.
Yeah, well, that's all Stephen.
He's a go-getter.
Yeah.
Yeah, I think what you said, like it was 144, but like that was about an hour ago that were registered.
So it's more than it was when I spoke earlier. It was 137 before.
Yeah, we're at about 146 now.
Oh my God.
Gosh. That's fantastic.
I'm not charging enough for this, Stephen.
Yeah, it also shows that there's an interest, like in the topic and stuff too. So, which is kind of what I was hoping, like that would be a good number. I honestly, like, I was hoping for just in the beginning, I was hoping for like 10.
Well,
so like now, like this is like way above and beyond like what I even expected. So
yeah, I remember when we first started talking and we were talking about a lunch and learn or something of that nature. And I was like, if we get 10 or 15, we're pretty happy. And so this is just, off the charts.
No, this is great. It's funny because I'm doing another one of these on Thursday for a local community services organization. I'm just part of a panel of 5. There's a psychologist, reproductive endocrinologist, attorney, member of the clergy, and somebody who does adoption.
Oh,
wow. They got it's an hour, and they got 37 people registered as of today. And my wife is one of them because she serves on the board of the agency. So.
Wow, that's great too, though. That sounds like an excellent panel.
Oh, it'll be fun. No doubt about it. But this is great to have this many people registered is phenomenal. It's a great way for people to get CEUs. They don't have to go out of the house. I'm assuming there's no basketball game tonight and the Packers are out of it. So what's there to worry about, right?
Yeah, there's a lot of people from all over. I know that there's some from like California, Texas, like Nevada, Washington, East Coast. I mean,
well, you put it up on the NASW board, right?
Yep. Yeah. And there was a good amount in the beginning, like one people that were just, like a lot of like LCSWs, but there's a lot of perinatal mental health. Like there is some adoption workers, foster care, social workers and stuff too. So there is a good mix.
Great.
Because I wanted to see like people like it. I think people see it as an individual thing, but they don't see that people in social work are working even with kids in foster care, and like that touches upon so much, like
yeah.
So just kind of like taking that another level, like of analysis and look at it and thinking about it.
Sure.
We've got people entering the waiting room, which is great.
So Angela, do you have any questions before?
I don't think so. I was going to say I'll probably mute my mic and my video here during the talk. And Gerald, I know we've just got you here at the start to make sure we don't have any issues, but have people reached out to you at all with any?
I haven't seen anything. It's
great.
I mean, I think we've got enough of troubleshooting in the email, and I'm hoping at this point a lot of people are pretty familiar with Zoom.
Yeah.
Of course, there's always snags. So, but I'll be on for about 15 minutes. I'll be muted.
At this point, we're all Zoom comfortable.
Yeah, It's a big. We all learned. It's a big improvement from 2 years ago.
No kidding.
I was telling a coworker of mine that I saw it on LinkedIn that somebody had posted a picture of the Brady Bunch and wondered how they got access to Zoom so early.
That's funny.
They had to square it. I mean, like it's just like I just cracked up laughing because it was just funny.
I still get a kick out of that one court hearing where the lawyer was a cat. He's he had the cat filter on. That still cracks me up every time I see it. So funny. Good times.
Let's see. Is Bill a co-host?
I hope so I can put my slides up.
Let's check the Stephen, it looks like you're the main host right now. Do you have an option to go over Bill's name and make him co-host or anything? I'm co-host and I don't.
I can't make him co-host, so yeah, it might be all you, Stephen. Do you know how to do that?
Yep,
you
just
go.
did it.
Okay, great. Then we're set. And yeah, let's see. 7 in the waiting room. I think we're good. We tested out the audio or the video earlier. That was great. So
Oh, good.
it was actually the best I've seen doing one of these.
Yeah, thanks for doing that. I mean, really
Yeah.
appreciate it. Do that ahead of time. So
Yeah, it was
It's not a problem.
very helpful.
Let's see, I'm still not seeing any thing come in. So I guess everybody's getting in okay.
So you guys got a lot of snow on the ground?
Not as much as we should have.
Skiing's
Where-
been lousy, huh?
It hasn't been as good. My kids snowboard. We live like 10 minutes from a ski hill, and my kids snowboard multiple times a week, and they're making the best out of it. They're still having a good time.
It's amazing. I've been watching the Olympics, and apparently it's all fake snow.
Yeah.
An amazing amount of it,
Mhm.
but all fake snow.
I know. I was watching the slalom last night when Michaela
Oh, and Michaela
Schifrin,
Schifrin? Yeah,
yeah, when she wiped out, and you have to wonder, like, is that artificial snow just riding different than, or was it the slope of that terrain that they were on? I don't know.
that was a pretty fast looking run.
Yeah.
And the
That's
fact that they couldn't get out and do any preliminary runs on it because of the wind
Right.
really makes things difficult.
I know. It's just, you feel like they should get another chance. Like, it shouldn't just be over.
Correct.
yeah.
She's got 4 more events.
Yeah.
Yeah, I'm boycotting the NHL right now.
Are you? Why?
They want to allow any of the NHL players to participate in the Olympics.
Oh, wow.
Really?
They put the kibosh on it. Like, they said that we need to make money. So like, they basically told all the players that they could not go to the Olympics and stuff for their countries. And so I'm like, that's, yeah. So I'm like, I'm watching the Olympics. I'm not watching NHL these 2 weeks. And
I'm surprised they did that and they just didn't slow the season down. I mean, what's the difference? Olympics, COVID, you just,
Yeah.
you alter things.
Hmm.
yeah, I mean, they could literally expand it, like they could in the every 4 years that happens, they could expand the season by 2 weeks. I mean, like, they could easily, but
Hmm.
I don't know. It's easy for me to say I'm not an owner. I don't have it as a living. So
So who do you root for anyway?
Washington Capitals.
Why?
So I started watching the NHL with my dad in like 1998, and that was the year they made it to the Stanley Cup Finals against Detroit.
Yep.
And they had Bondra and Gonchar and Kolzig, and I really liked their style of play. So I just started watching them, and oddly enough, my aunt lives in Arlington, Virginia, and she's literally like a block away from their practice facility. So
Say no more.
That's awesome.
yeah. So that's how I knew about the Baltimore Skipjacks as being
Right.
the minor league team. And they played at Baltimore. They won at the Baltimore Arena.
Yep. I almost did their EAP for them because there's a significant amount of alcohol problems in minor league hockey players.
Well, I would imagine.
Wow.
They opted out.
They
It was
opted
too-
out of the EAP.
Well, it was too bad. I mean, the one of the guys I knew was a part owner, and he was all for it, and the coach was all for it, but the rest of the ownership didn't want to put up the money for an employee assistance program.
Oh, that's too bad.
It was too bad. It was really too bad.
Well, listen, I'm going to mute my mic and video, and we'll want to start letting people in here pretty quick because it'll take a couple of minutes for them to all trickle in. But I'll leave it in your good hands, but I'll be right here if you need anything, Stephen.
right, sounds good.
Good to meet you, Angela. Thanks.
Good to meet you. Thank you so much for doing this.
Sure thing.
Okay, I'm gonna mute and turn off my camera too because it's almost burger time. My wife's making hamburgers, so that's why I had to run in real quick. But I'm gonna be watching, and I don't see anybody asking questions yet, so that's still good. Normally,
Good sign.
yeah, normally around this time you've got a whole bunch of people saying I can't get in or my browser's not working. So, but we'll wait. We'll let everybody in and then see how it looks. 34.
Yeah, Bill, I know that Esther Tressor Polanco had messaged me on LinkedIn because like she wasn't getting, I think she registered like later and stuff, but she had messaged me on LinkedIn, whatever, make sure that she had the information because she wanted to attend.
Not like she's never heard me do this before.
Well, I think she just enjoys hearing you talk. So,
Okay, so I've got my video stopped, and well, it's 5:59. Do we want to start letting people in?
yeah, that sounds good.
Okay. See if
I
can-
figured maybe about like 6:03 or something, give people a few minutes to kind of trickle in.
Sure. Okay, we've got 38 coming in. Here they come.
Well, everybody, I just wanted to thank you for all for coming. We're going to give people a few minutes, just as people are trickling in, and probably start about like 6:03, 6:04, and we can get started. Right. Well, I think it's starting to slow down a little bit, so I think we can get started. So I want to thank you very much for coming. Really appreciate it. And I just want to welcome you to the opening session of webinar series on reproductive mental health. And so I'm Stephen Miller, an MSW student in the part-time program here. And before I introduce you tonight to our speaker for tonight, I want to acknowledge on behalf of the Sandor Rosenbaum School of Social Work that our University of Wisconsin-Madison campus is on the shores of Lake Mendota, which is the sacred homeland of the Ho-Chunk people, a place that they call today Jope or Four Lakes. Since our university reaches the four corners of our state, we also recognize the inherent sovereignty of the 12 First Nations of Wisconsin. And whether you're watching from a land of these 12 nations in Wisconsin or Murchiston, we encourage you to learn about the history of the land that you are on. So I wanted to share one of the reasons why I wanted to develop this series is my wife and I both had struggled with infertility, and it took us probably close to 7-8 years to be able to have our boys who are now 3 years old, which is giving me a run for my money. Definitely energetic. But reflecting backwards, I quickly realized that there is kind of a lack of mental health resources for this, for people going through infertility and just the struggles of it own. And then once I got into the MSW program, I realized we don't really talk about this at all. And I'm thinking as clinicians, as future clinicians, and even in current, right, if we're not talking about it, how are we supposed to help serve those that are struggling with infertility that may come, to seek counseling? So this was in an effort to provide more awareness, some education, and just highlighting just what, like the struggles are from both the cis male perspectives and then the other perspectives along in the webinar series. So that's a little bit about the reason why that I chose to do this. And a few details before we get started. The presentation is being recorded. As usual, like what we normally do is with the Q&As, like those will not be recorded. It'll just be the actual lecture of the talk. We also know about CEUs. If you're registered, you're set with the CEUs. To access the presentation, you are required to provide your name and email. This allows us to verify the attendance, and you'll be getting the CEUs for this presentation by email in the coming weeks. So, without further ado, it is a great pleasure to introduce Dr. Bill Petok, who has been an amazing person to me, and teaching me a lot of knowledge and giving me a lot of room for thought. So Bill has worked in the field of fertility since 1985. He has served as a board member of Path to Parenthood from 2007 through 2017. He is a past chair of the Mental Health Professional Group of the American Society for Reproductive Medicine and is an associate editor of topics in obstetrics and gynecology. He is also on the executive council of the Society of Assisted Reproductive Technology, where he chairs the branding committee. In 2015, he was appointed a clinical associate professor of obstetrics and gynecology at Sidney and Kimmel Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania. He is a licensed psychologist with a practice in Maryland that focuses on reproductive health issues, including fertility and sexual function. He has a special interest in male reproductive health. He has presented widely on the mental health issues men face regarding infertility, including at the United States Centers for Disease Control and Prevention. In addition to his employment as a psychologist, Dr. Petok's other professional activities include the co-production of 2 films for training therapists, a co-edited book, multiple journal articles, book chapters, and regular presentations at state, national, and international conferences. He has served on the boards of numerous nonprofit organizations as well. Originally from Detroit, Michigan, Dr. Petok relocated to Maryland when he entered graduate school in 1972. So as a fellow Michigander, here is Dr. Bill Petok.
Thank you very much, Stephen. You make me sound better than I really am. First of all, it's a real pleasure to be here with everyone. I want to thank the School of Social Work for making this series possible. I think it's a wonderful opportunity for everybody to learn about something which you don't typically get a chance to. Stephen, do you have the little questions? We're going to put up a little pre-test for you, and I'd like you to take a look at these.
And there, can everybody see that? Okay. So these are all the questions that they took prior, well, as they registered.
Okay.
So I'm sure everybody will be curious to see what the answers are.
So I'll give you answer number one. 40% of infertility is male factor, and about 40 to 45% is female factor. The rest of it is combined. So if you look at the total amount of infertility, about 50% involves men.
Yeah.
Question two. Male infertility does not cause psychological distress in men. You wouldn't be here if that were true. So the answer, of course, is false. Stress has no impact on male fertility. Interestingly enough, there is data which suggests that stress does have an impact on spermatogenesis, which has an impact on male fertility. So the answer to that is true. Stress does not cause infertility, either in men or women. Male infertility can be caused by genetic diseases, environmental and lifestyle factors, physical health issues, and of course, all of the above would be true.
Right.
Okay. So I'm going to share my screen with you now. And okay, nothing serious to disclose. These are the learning objectives. Hopefully you'll have an understanding of men's understanding of infertility, how men access and utilize mental health services, the differences between men and women and their coping with infertility, and some variables that yield optimal utilization of mental health services by men dealing with infertility. Let's start real simple. What is the definition of infertility? Well, in the broadest sense, it's the inability to conceive a child. The World Health Organization says you have to try for 2 years. They don't define regular sexual intercourse, but for our purposes, it would be penis and vagina intercourse with ejaculation intravaginally. So as many of you who do work with sex, you can't say, do you have sex? You have to say, how do you have sex? Because sex has a rather broad definition. In the United States, we define infertility for a woman under 35 if she is not conceived after 12 months of contraceptive-free intercourse. And if she's over 35, if she is not conceived after 6 months of contraceptive-free intercourse. Note, there is no definition for male infertility here, and we'll talk a little bit about that, why. 2 other things for you to know: primary infertility, a couple who have never had a child; secondary, a failure to conceive following a previous pregnancy. You could ask which is worse, primary or secondary, and I would say ask the couple who's dealing with it, and they will both tell you it doesn't matter. It's devastating either way. Let's talk about a little about some myths that float around about men and infertility. The biggest one is that it's a female problem. Not true, as you saw the statistics before. It's linked to sexual problems. There is this conflation of fertility and sexual prowess for men. Of course, you could have a sexual problem which leads to infertility, such as an ejaculatory disorder, but that would not necessarily be a cause for infertility in the classic sense. Men don't care about having babies. You heard Stephen, men do care about having babies. Men don't have emotional reactions to infertility, another myth. And men won't talk about their feelings, and you can probably come up with others. Of course, men have emotional reactions to infertility, and of course, men do talk about their feelings, just not in the same way that women do. Some thoughts about why these myths exist. It's a collective belief held with no basis in fact, right? Well, popular literature does not focus on male issues with regard to fertility. You're not going to read stories in People magazine or in Time about men who have difficulty conceiving, but you all know about Celine Dion and her struggles. There's been a problem with the way the science has been presented on it. Many physicians initially ignore male factors when they're doing the testing because it is usually the woman who presents in the OBGYN's office. It's been neglected in medical research. There's a, relatively speaking, about a 1/3 to 2/3, about 1/3 of the research published on infertility deals with men and about 2/3 with women. It's missing in the psychological research, and I'll show you a slide on that in a minute. This is the quote here is from an article in 1986. I'll show you some more current dating. And the science of male reproductive health is missing. And anybody who's interested in this, I would recommend Renee Almelink's book, which is in the list of resources, which is at the end of the slides, and you'll all get a copy of the slides if you wish. But Renee has taken a look at how the science of obstetrics and gynecology developed and how urology or male reproductive science went by the wayside and has made a comeback, but science has dealt men a bad hand here. Here's some discrepancy in this professional literature. This is in 2017. If you Google gender and infertility, so male and infertility and female and infertility, what you will see, the orange bars are PsycInfo and PubMed, so you can get a chance to look at the difference between psychological as well as medical research. The medical research clearly far more about women and significantly more about females when you come to the psychological research. If you did this again today, you would probably get the same spread. The question is, are men fertility aware? Well, it's a really difficult question. No, yes, maybe. Of the studies that have been done, women know more in 12 of them. There's no difference in 10 of them. And most of these are university student samples. And then there were mixed results. But we know that with higher education, there's greater awareness. And we also know that those studies had lower numbers of male subjects. You could ask, why is it that men know less about fertility? And the answer, while complicated, would include the fact that women receive much better reproductive health care at an earlier age. In fact, a woman who's receiving good reproductive health care is having a visit with her OBGYN on a yearly basis. The time that a man goes to see a urologist is when he's got a problem. And for most men, that doesn't occur until much later in life. So their awareness is much lower. A colleague of mine here in Baltimore has done research with adolescent males and found that after the age of 5, men, at least in cities, tend to get less health care than their female siblings. I could spend a lot of time talking about that, but Eric Marcel, the author of the studies, would be the person to really have here to talk about it. Some more myths. Men are over 35 are twice as likely to be infertile as men. And these are not myths, these are facts now. So we think of women as having a drop-off in fertility at age 35, and you saw that definitional information before, which suggests that that is very true, although there may be something less magical about age 35 today than there was 20 years ago. But with 10 years, men are likely to be twice as likely to be infertile at 35 as they were at 25. So age does play a role with male infertility. Clearly, the genetic quality of sperm declines with age. There are more microdeletions on chromosomes, leading to more abnormal sperm, leading to more abnormal embryos. 2.5 million men in the US are infertile or subfertile. That's about 10% of the men trying to father a child at any one time. That is a very significant number of men. There are about 75,000 babies born annually. This was data from 2021, which really looks at data from 2019. SART, the Society for Assisted Reproductive Technology, reports outcome data on about 85% of the IVF cycles in the United States. This is mandated by law. And it takes 2 years to validate the data because it takes 9 months for a baby to be born. So we're behind on that data. But of that, interestingly enough, and there's no data on this that's firm like the SART data, about 100,000 babies are born from donor sperm in a year. This is a very significant number of babies. Some ideas about what creates normal in terms of semen analysis, a concentration of sperm about 20 million per milliliter, about 60 million in the sample, a volume of about 1.5 milliliters, movable modal sperm, about 30 million, viable sperm, about 50%, normal shapes, morphology, about 60%. So you can see in any one sample, if 50% are doing good, it's considered to be normal. Moving into the mental health side, do men care about fertility? The research here has been clear, but difficult to obtain. One of the first studies determined that it was too painful to talk about. McNabb sent out surveys to 500 men and got 15 responses. It was too painful for them to talk about it. Mason, whose book is listed in the resources, said that once she contacted men, they were more willing to discuss, but in searching for subjects, it was difficult to do. There is some specific self-help literature. My colleague Leslie Scover and her partner Thomas have put out a wonderful book on it. There are a variety of anthropological and cultural studies. Marcia Inhorn is probably the leading author in that area, and I have one of her books listed, and you will find it there in the resources. Has written extensively about different cultures. If you look at sub-Saharan Africa, it's an entirely different world with regard to fertility based on some cultural things that may be influenced by religion and also by tribal issues. And then contemporary literature, while there is not much about men, does have some. Michael Chabon's 1999 book about the wolf man is a very interesting piece of literature that does deal with the fact of male factor infertility. We know that infertility can stigmatize men. It creates deficits in their power, and they feel powerless in their masculinity because they are unable to conceive. It violates that norm of producing children. Most of us believe that we will get an education, grow up, find a job, meet a mate, and then have a family. And when that is violated, that can be very stigmatizing. As I said before, the conflation between sex and fertility is very powerful. We tend to refer to men who are unable to conceive as impotent, and impotency is often seen as erectile dysfunction. And so men will talk about their failure as sexual beings because they're unable to conceive. The role failure of being one who produces a child is another issue that can stigmatize men. And the self-esteem of not being able to do what you had always believed you would be able to do is problematic. There are possible sexual aftermaths. We know that men who have male factor infertility have an increased incidence of erectile dysfunction. It can lead to feelings of irrelevancy in the creation of life, and therefore a decrease in sexual desire. I do an awful lot of talking about sex and infertility, and in a shameless plug, Kim Bergman and I have just released an edited volume on psychological and medical perspectives on fertility and sexual health. And there are several exceptional chapters written by colleagues of mine on male reproductive health, talking about not only what kinds of medical issues are involved in male factor infertility, but the psychological and sexual components as well. But we know that if you are having difficulty conceiving and sex and conception are tied together and you keep failing at conception, it could significantly decrease your sexual desire. One of the other things that we see with couples is that they tend to focus very closely on that fertile window, that 3 to 5 days when conception is possible, and their sexual activity tends to be focused there. There are at least 25 other days in the month where sex is possible, but because couples are so intently focused on that, sex loses the other several meanings it may have. Obviously, conception is one, but certainly relationship enhancement and even stress reduction may be other reasons for having sex, and those tend to go by the wayside the longer treatment or infertility goes on. I want to show you a little video that it's a man talking.
2 years. And
I get choked up every time I watch that. And I've probably watched it 20 times. So men don't have emotional reactions to infertility. Well, you just saw a man having quite an emotional reaction to infertility several years after he had his twins. The research literature says a lot of different things. Do men suffer less than women or not at all? Are they sturdy oaks? Well, if men are such sturdy oaks, psychological intervention wouldn't be necessary. But it appears that the variation within gender is as great as between the sexes. So number one is not true. Men do have significant psychological reactions. You just saw it. What is the psychological impact of male infertility on men? I think an awful lot has to do with how it is presented. You know, if you've been told you're shooting blanks, it's very different than somebody having a good sit-down conversation with you and helping you to understand exactly what has gone wrong, whether it is a problem with the delivery system, whether it is a problem with the production system for sperm, and having a sensitive physician be able to explain that and then make an appropriate referral is very critical. But we do know that men who have received a diagnosis tend to feel that they have a reduced quality of their personal life. Clearly, there's an increased sexual dysfunction, and cultural differences do make a significant point here. Because in some cultures, if a couple has not conceived, it is never the man's fault. It is always the woman's fault, and he is allowed to divorce his wife and find a new wife, even though that may not produce a child. So really, we know that Mason's work in '93, which was done in Great Britain, she teased out from interviews with a significant number of men, they felt a variety of emotional responses: pain, guilt, shame, anger, isolation, sense of personal failure. Subsequently, when we start thinking about the losses and this compromised definition of who I am as a man, you know, he's got a failure to create. So he's lost the ability to produce a commodity, if we want to think of children as that way. He's lost by virtue of the failure to continue his name or genetic line. And that's a loss that, even if there is a solution such as donor insemination, and we'll talk a little bit about that later, how that might have a significant impact. The ability to control your own life or destiny by virtue of having an heir, and your sexual identity, if your sexual identity is wrapped up in your ability to produce a child. Now, it may be wrapped up in other things, but these are a variety of different losses which men have described. And would you be depressed? Well, you saw David Nail's wife talking about the depression. You're all mental health professionals. You know that you can be depressed for no reason. You can be depressed for a good reason, or you're just depressed and don't want to analyze it. And for some men, that may be the case. But this would be being depressed for a very good reason. Like I said, there are some gender-based differences. Do men and women react differently to infertility? Absolutely. There are some common wisdoms. Fertility confirms virility. So the loss of virility may be the most distressing for men. Men desire children less than women. Therefore, infertility is less distressing to men. Interestingly enough, the data says that it's about equal for men and women aged 31 to 40. And if you think about that age range, significant for women, many women will say, I hit 30, I didn't want kids until then, and all of a sudden I realized my biological clock was ticking. And men don't have the same biological clock. It's not running in their heads. On the other hand, if you think about being an older father, there is something else that is running in your head. When I talk with older dads who are using donors, we always have a conversation about what it's going to be like to be 45, 50, 55, take your kid to that little league game and have another parent come up and say, isn't it nice that you brought your grandfather to the game with you? So that 31 to 40 bracket for men, pretty much the same as it is for women in terms of desire to have children. Men and women are different. I've got a couple of cartoons that highlight the differences. Don't need to say too much about that. Here's some other comparisons when it comes to infertility and emotional reactions. Women appear to have greater levels of distress, and then they seek information to reduce their distress. So they go online, they talk to other women, they'll talk with their physician, and they will access family support systems far more regularly than men do. So talking to mom, talking to sister, talking to cousins is not an unusual thing for women to do. Clearly, when it is a male factor, men have a more negative response because it is about them, which makes an awful lot of sense. They tend to be self-denigrating in the way they talk about it, but they don't talk about it very much. It is not the kind of thing that you do when you walk into work. And they are less likely to seek social support than women, and there are a variety of reasons for that, which I'll talk a little bit about later. Interestingly, the data indicates that support from their physician is the best for most men. That may be problematic if the physician they are working with regard to infertility is an OBGYN. Typically, what will happen is a couple will go in for fertility treatment. A smart reproductive endocrinology program will have the man get a semen analysis right away. They may have a urologist on staff who does that. They may send him out to a lab for it and get the information back. If the physician is good at approaching the man and saying, you know, there are some things we can do to help. There are some treatments that are available, and we do have a support system built in. We do have our clinical people who are available to talk with you about the emotional reactions. That may be good, but that's not often the case. What happens when a couple goes into reproductive endocrinologist's office, they are all OBGYNs. And they tend to speak more to the women than they do to the man because they're typically treating women. And men tend to be less likely to ask questions for fear of appearing uneducated or just plain stupid about what's going on. And you'll remember that information from before about fertility awareness. So guys may be less aware and less comfortable asking those questions. So it's a real conundrum for guys. So we have to talk about men and mental health usage because now there's this interface. You've got this fertility issue. There are all of these issues which are going to come up in one form or another, in one intensity or another. And what about guys using mental health? Well, we know that men have fewer visits than women on a yearly basis. It's unexplained by need. There's no difference in the rates of psychopathology. It just tends to present differently. So in general, men have externalizing disorders, substance abuse, gambling, infidelity, that sort of thing. And women in general have internalizing problems like anxiety and depression. But that doesn't mean a guy can't be anxious or depressed, and many of them will tell you that they are. And there are social expectations for men which get in the way of their using mental health. Men are supposed to be emotionally in control. They are supposed to be strong, which means being able to handle things that are thrown at them. They should be independent, which means you don't go and ask for help. You figure it out on your own. And they should be self-reliant, which is just another way of saying independent. And so they're less likely to disclose a mental health problem because it suggests a failure. And most men, most women also, don't want to feel like a failure. Probably more prevalent in the male side of this equation than the female. I want to talk a little bit about how men think about therapy, because this is a critical issue in terms of providing psychosocial assistance to men who are dealing with infertility. Western culture, and I'm speaking primarily to people who are working in Western culture, requires men to be strong, handle the rigors of life stresses, and control their emotions without seeking help. That's what a strong guy is. That's that sturdy oak sort of concept from before. A significant determinant in deciding to seek mental health services is the endorsement of that behavior within a person's social network. So if your brother saw a therapist or a counselor and said it was a good thing, you're more likely to. If your best buddy did, you're more likely to. But if your friends don't talk about the fact that they saw someone, or your brother doesn't mention that he saw someone, then you are less likely to know about that if you're a man, and less likely to seek out mental health services. And if you've got a higher gender role conflict, you're likely to have greater negative attitudes towards counseling, and you may even see help seeking as a threat. And what do I mean by gender role conflict? Well, a manly man is supposed to behave in a certain way. And if you are wounded because of your fertility, there's a conflict with your gender role. And so guys who have seen themselves as much stronger in that manliness may have a greater difficulty in going for counseling and find it a threat. So what do men do about treatment? Well, this quote here from Patton, and it's a 6-year-old study, 7-year-olds almost, but let me just read it to you because I think it makes a lot of sense when you listen to it. Because of this gendered role conflict, men may be reluctant to seek professional care and may fear greater stigma. Remember, you're stigmatized already if you are infertile, if they do seek help. With regard to treatment, men are more likely than women to choose to deal with mental illness on their own and to rely on self-care options, in part because they do not want to end up in a subordinate relationship to a healthcare provider. If they do seek professional treatment, men seem to prefer a quick solution, one that is not time-consuming. Can't we get this over in a session or two? And so that creates a conflict for men. When you think about it, many of the characteristics which are considered desirable in a psychotherapy client are traditionally feminine. So a clear expression and verbalization of emotions, the ability to discuss personal pain, the willingness to be vulnerable, and turning to others for help resolving problems are typically seen as good characteristics, and they're not very manly. If any of you have watched Ted Lasso and gotten to season 2, I hope I'm not doing a spoiler here. The team hires a psychologist to work with members of the team, and Ted is conflicted about meeting with her, and he finally goes in and sits down with her, and she's got a box of Kleenex on the desk, and he picks it up and throws it in the corner and says, "I'm not going to use this," or words to that effect. And it's a classic example of what a guy thinks about therapy. In the last week, I've talked with several men who were referred to me for therapy regarding fertility-related issues. And inevitably they say, "I've never done this before. I don't know what to do." I start by saying, whatever you've seen on TV, forget about. Whatever you've seen in the movies, forget about. We're going to talk about how this could be useful to you in helping you to understand and or work with what's going on. So here's some things to think about. Men are socialized to cope with stress differently than women. We are to take it on ourselves. We are not to talk about it. And in fact, when you think about the two best coping mechanisms that men utilize, the two most frequent coping mechanisms that men utilize, they are denial and avoidance, which means we don't do very much in an outward way. So it's a very different way of managing coping with stress. Oftentimes in a fertility situation, the guy will suppress his emotions to support his female partner and say things like, "Well, I can't get too emotional about this because I've got to be available to her, and I see how hurting she is. So if I were to let her know that there was something wrong with me, I'd be destroying her." Now, of course, we're all professionals. We know that that's not true. And in fact, many times, the fact that a guy will disclose how he feels and that he's hurt by the situation may be something that strengthens the relationship. because it is a sign of vulnerability, which gains a fair amount of respect in some certain situations. So what these guys will do is they will withdraw. And then she's wondering, what the hell's the matter with him? Aren't you upset too? Why aren't you being open with me about how you feel? Of course, there are cultural differences. And so in certain cultures, it's okay to talk about how you feel. In others, it is not okay at all, which leads to being very culturally sensitive if you're the therapist working in these situations. Surprisingly, there's a fairly large African community that lives in Baltimore. And so over the years, I have learned an awful lot about different cultures within the continent, and have learned that in certain cultures, you do not ever discuss fertility because it is just not acceptable to do that. And certainly some of the treatment options for specifically male factor infertility can raise emotional turmoil. We haven't talked about the medical treatments because that really wasn't the focus of this session. However, it is possible for a man who is not producing viable sperm, or at least not able to deliver it directly, it is possible to obtain sperm through surgical procedures, which either involve aspirating sperm from the epididymis, or actually opening the scrotum and opening the testicle and finding viable sperm there. And when I say words like that, men in the audience tend to close their legs a little bit tighter, and women have similar feelings for those guys. So you can imagine when a physician says, well, we do have a treatment available, and what we're going to do is we're going to cut your testicles open and look for sperm, that it could raise some level of emotions in a guy. Men are different than women. There isn't any question about it. We buy things differently, and I'm going to show you a slide about that in a minute. We cope with infertility differently, and I've been talking about that. We seek help differently. If you go look at the research on men seeking help for depression, men with low levels of gender role conflict and low or negative help-seeking attitudes were more than willing to go get help, but those who didn't were less. And we know that men are more comfortable talking about activities than emotions. It is unusual for a man to walk into his place of work and say, so how did you feel about X, Y, or Z, as opposed to what about that game last night? Much easier to keep it at a distance than to make it in close. Here's an example of how men buy differently. The blue, a guy's going to buy a pair of pants at the Gap. Total time 6 minutes, cost $33. It's an old slide, probably about 45 now. And a woman will do things differently. Obviously, this is an exaggeration. However, it's not that great an exaggeration. The important thing is that men and women do things differently. And if she expects him to behave the same way as her, or he expects her to behave the same way as him while they're dealing with a conjoint problem, that's going to raise some issues. So what do we know about men therapy and infertility? Well, they're more likely to seek therapy when others in their social network endorse help seeking, like I noted before. So if he knows someone who has dealt with infertility, he is more likely to go seek help for it. Unfortunately, when you talk to an awful lot of men who have received a diagnosis and they've been referred to you and eventually make it to your office a couple of years later, and you ask, who else have you told? They will say, no one. I couldn't tell my brother. I couldn't tell my best friends for fear of the way they would think about me. And there is this increased stigma, as I mentioned before, leading to reduced help-seeking behavior. And infertility has a higher stigma for men than women. In part, that has to do with all of those things I showed you before. Less research on men and infertility, less awareness by men about infertility than women, and less public discourse about male factor infertility than for female factor infertility. I mentioned Celine Dion before. I showed you David Nail, but I'd challenge you to name 3 other men who have talked openly about their own infertility. And when we get to the end, if there's time for Q&A, I'll be glad to tell you who those guys might be. But you can probably come up with at least 10 women who have talked very openly about their own infertility, and therefore reducing the stigma for other women. Not removing it, but certainly reducing it, because there's somebody else who's been willing to talk about it. And this leads to a lot less help-seeking behavior by infertile men. So what do we want to do to make things better for these guys? We want to optimize interventions with men. And there are 4 things which I will talk about: language setting, pacing, and the removal of stigma. So if you're treating guys who are dealing with infertility, think male speak. What do men talk about? We talk about work, we talk about sports, we talk about home repairs. Can't talk about kids because he doesn't have them yet. But those are the things that we tend to talk about. And it's easy for us to talk about that. It's much harder for us to talk about other things. What do we avoid? We avoid emotional discussions. So words like feelings and therapy may be problematic. You may want to use, and I'll talk about that a little bit down at the bottom there, other kinds of language. And how do we cope? Denial, avoidance, and problem solving. So here's a problem. You're infertile. So what do? Well, you try harder, or you go see the doctor, or what do you do when there isn't a solution? Using a donor is not a solution for male factor infertility. It is a way around the problem, but it doesn't stop the guy from being infertile. So we get stymied with the problem solving part because frequently it's a problem we can't solve. When you think about how to talk with men about this, you need to think about the language that appeals to men. Guys are real good with meetings or consultations for team efforts, doing things which are cost effective. We're going to tackle the problem, but we're not going to explore our emotions very easily or talk about the psychological insults we have suffered. So framing your language in a way that is male-centric is very helpful for providing the assistance that he may be coming in for. What are male settings? Consultation rooms, not therapy rooms. A neutral decor is going to be much better than a feminized decor. Guys want times that are convenient, not the middle of the day, but after work. Don't we all want after work times for things? And most of us don't want to work after work. I threw this in the design of specimen collection rooms just as a something to enlighten you about. When a guy goes to give a semen specimen, he's usually handed a cup and told to walk down the hall, and there's a room which is the collection room. Or he's told to go into the room and there are cups there. And there may be stimulus materials available for him. That may be printed material, it may be audiovisual material. And his job is to produce a semen specimen. And then sometimes there's a pass-through door where he opens the door, puts the specimen in, and there's another door on the other side at the lab and they take it out. In the old days, he had to put it in a paper bag and carry it to the desk. You can imagine how guys feel walking down the hall to the room where everybody knows what they are going to do. This can be incredibly embarrassing. Oftentimes a guy will be allowed to give a specimen at home as long as it's not too long of a drive and he can keep it at body temperature and bring it in. Men want a slow approach to their infertility. There's a lot to manage. All of those issues that Mason identified back in '93, and they don't jump in too quickly to talking about those things. The one case where it took a guy 2 years before he would talk about the fact that he was infertile, talked about his wife's infertility right away. And what we wind up doing is creating interventions to increase a sense of competence. So instead of unhealthy, soothing behavior like drinking too much or doing too much of anything in excess, try and teach them other kinds of relaxation techniques, meditation, and we want to help them reduce their maladaptive behavior. And there are many ways that a man could maladaptively behave. And I don't need to tell you what those might be, but we want to increase his sense of self-confidence. Give him information that helps him make good decisions about treatments that may be available to him. One of the things that has developed over the last few years, and all of us are participating in it right now, the availability of the internet as a way of learning, is the notion of cyber support. There are wonderful support groups for women. Resolve, the national support organization for people dealing with infertility, runs at least 500 groups for women all over the country. There aren't a lot of groups just for men. And if you've ever tried to run one, it's a pretty hard deal to do. However, cyber support groups have started to break down these barriers, and they allow a man to be anonymous. He can have a handle when he logs on. His face doesn't have to be there. They're safe. If you are an ethnic minority, you are not going to feel left out, because it may just be a listserv with information going back and forth, or it may be a non-visual chat room. The research that's been coming out primarily out of Great Britain and the continent says that the insider-only male support is valued. So everybody in the room's dealing with fertility issues, and everybody's a guy. That's got a high value. It's okay to share in those situations because you know everybody's dealing with the same thing. Guys use male language. There's not a lot of medical leads. There's not a lot of psychobabble. And this concept of hegemonic masculinity, which some of you may have read about, it may be present in those rooms, but if guys are talking with other guys about their problem, that's the most important thing. They're connecting and allowing themselves to let down their guard, talk about what's physically, psychologically going on with them. There are some digital interventions. Ferta Strong, it may be in hiatus right now. There's a female copy, Ferta.com, which is put out by a couple of my colleagues and supported by large institutions. These are apps which are free and downloadable. There are some groups online, Infertility in Men. This is one of those groups. And if you want it, whoops, let me go back. This YouTube series is entitled Urology Nerds Drinking Beer. 4 of my colleagues put together a series of YouTubes where there are 4 urologists talking about the issues that men present dealing with fertility. And I highly recommend it because it's done pretty much in guy talk, not a lot of medicalese. Very briefly, if a man is using donor insemination, there is the challenge. Will he be giving up a genetic connection, or will he be creating a parenting connection? Those of us who work in the field talk about the fact that parenting is probably the most important thing, at least from our point of view, because parenting is what takes place after the baby is born until the child is launched, hopefully by the age of 25. The genetic connection, less so. And when you talk to donor-conceived children, it's the parenting that is the most important to them. There is the question of secrecy versus privacy. Secrecy can create problems. Privacy is a different story. Who you choose to tell, what you choose to tell, when you choose to tell is one thing. Who you choose to disclose to, family and friends you may or may not want to. The child, probably a good idea at some point. And so we work with guys to talk about how they might tell their children about their donor-conceived status. And as a way of making it a normal way that people do build families. We tell donors today that anonymity is a myth. 23andMe, Ancestry.com, and the internet make it impossible to hide. And many of you have probably seen stories on 60 Minutes or other places where the guy who's got 80 offspring from his donations finally meets 10 or 12 of them. So just in summary, it's going to be important to get his understanding of the diagnosis. Like I said before, men don't ask questions because they don't want to seem dumb. So you're going to help him with that. You're going to find out what his beliefs are about infertility and what that means. You're going to explore his feelings and his understanding of his partner's feelings, because those will be important. He may not understand them at all. And if you're working with a couple, don't allow the woman to take over the session. Help him develop a vocabulary and help him to feel competent. I'd like to end with a joke. And you'll get the suggested reading list. I'm going to stop my share. And Stephen, I guess we got a couple of minutes to either do post-test or Q&A. Let me see.
So I will put the post survey like in the chat. But if people have questions, the floor is anybody that has a question. You can either put it in the chat or you can either, you can just unmute and ask it.
Kathy. So I practice in Mount Washington. Stacy asked, where do I practice in Baltimore? It's in Mount Washington. But for the last 23 months, I have practiced virtually pretty much everywhere. SIPAC, a compact between 27 states now, allows licensed psychologists who have the SIPAC credential to practice across state lines virtually. So my practice, COVID has unfortunately been good for my practice. Yeah, I can say a little bit more about, can I say a little bit more about the impact of stress on sperm? There appears to be data, mostly in animal models right now, but we believe that they will translate very well to human models, that excessive stress causes some declines in spermatogenesis. There's a little bit of data out of Israel high and get some more lower outcomes with spermatogenesis. Chronic stress is bad for most medical systems. My colleague Ali Domar has written a wonderful book, Healing Mind, Healthy Woman, which is an exceptional look at the impact of stress on many medical kinds of conditions. So it looks like stress has an impact on spermatogenesis. Doesn't cause you to be infertile, but it may cause changes in sperm parameters leading to lower likelihoods of the conception. You're welcome.
All right, is there any more questions?
Is lack of treatment a determinant of further waning potency? That's a great question. I would say, depends on what the treatment is. So if there is viable sperm and it can be extracted surgically, and you can use intracytoplasmic sperm injection where you need one sperm and one healthy egg, will that cause your potency to wane? No, you need the one. However, we know with age, there are changes. So if you don't do something about it early on, it's likely to decline over time. So a guy who's got nominal sperm parameters at 35 is likely to have even lower parameters at 40. But in all likelihood, he's not going to take something that will have him produce more sperm. There may be some supplements which will help. They are sold. Some men report better outcomes. I think the data is highly variable on that. Not a lot of randomized controlled studies in that area. But good question. Thank you. And let me say one other thing about treatment. One of the causes of infertility can be something called varicocele. And that is a condition where the veins grow around the testicles and increase the temperature of the testicle, decreasing sperm production. So that is one treatment where you remove the varicocele and you lower testicular temperature, you can increase spermatogenesis and return it to a more normal level. But there are very few treatments like that. That's one very clear one.
We have another question.
Okay. Let's see where it is. Do I have a favorite question in intake session to gauge where the man is at emotionally? That's a really good question. Do I have a favorite question? I usually like to say something like, getting a diagnosis like that, if he's told me his diagnosis, is frequently frustrating. I don't like to say destabilizing. Frequently came at you out of the blue. You weren't intending, you didn't think you would hear that. I wonder what your reaction was. I am loath to say, how did you feel? For all of the reasons that I cited before. Later on, we can talk about feelings, but let me just get his temperature, his emotional temperature first. So how did that strike you? What was your reaction? Those are sort of neutral, more neutral kinds of questions to ask. You're welcome, Emily.
Maybe have room for maybe one more question if people have one.
Well, let me just say, I really appreciate the opportunity to talk with you. Thankful to the School of Social Work for having arranged this. I'm thankful to Stephen for having made it possible. And it's so nice for me to be able to sit in my home and connect with so many of you at one time. Thanks again.
So I'll say I really appreciate you taking the time out of your day to do this. And like I said, like the post survey is in the chat. I can post it again as well. Would really appreciate your feedback on this. And yeah, I just wanted to thank you. It's something that's near and dear to my heart and something that I strongly believe that we should be having more education about, and also wealth of knowledge. I'm glad that he came. And if there's any other questions or anything, like I'll put my email in the chat as well. I am also I've been on one podcast, and actually there's two other podcasts and stuff that are pending upload. But just talking about infertility and mental health, and I kind of share a little bit of my story along with that as well. So I also want to give a shout out to the American Society of Reproductive Medicine too, and the mental health professional group. I joined that in February of last year, and it has been a wonderful experience in meeting new people, and it's been a wealth of knowledge and just learning about these different aspects and things that I never would have, thought about. And yeah, really appreciate it. Especially on the NSW discussion board and stuff. I really appreciate it. I know a number of you that saw that and decided to share your time with us tonight. So rough time, I would say probably, I have your slides. So I would say probably within the next week, I would say that we would be able to send that out.
Great. I'm just putting something in the chat. Another podcast series. Stevens is very interesting and is really targeted. The SART Fertility Experts podcast series is something that is patient oriented. And if you want to hear, now in season 3 is out, and it's interviews with experts in the field. Season 3 is interviews with patients. I did an interview with a gestational carrier and her and the intended parents, and they're very enlightening when you get to listen to what people are interested in and what people really say about their experience. Just another thought for you.
Yeah, absolutely. And it's what I actually frequently listen to, that and the ASRM podcast. I mean, listen to them every month. Okay, well, if there is no other questions, Angela, did you want to say something?
No, I was just gonna chime in and say thank you again so much. This was excellent. So much great information.
Thanks again for the opportunity.
All right, so we'll hang on for a few minutes, but if you want, like I said, like there's the Qualtrics survey in the chat. If you could fill that out, then that'd be greatly appreciated. And I thank all of you for your time with us this evening. Well, I feel that went very well.
Yeah, no, it was good group.
Yeah,
And thank you for the opportunity.
no problem.
So your next week is the next one?
Yep, the 17th. So Anna's doing that one. And then the 23rd, we're talking about like third-party reproduction and mental health. And yeah, so we have Jan Ferguson, who's actually one of our professors at UW. And then Bree McKellar is a donor specialist and stuff. So
Great.
they're doing that one.
Super. That'll be really
Yeah.
good.
Well, and if there's any opportunities for me to speak to, I'd be more than willing
I
to do so as well.
I just had a conversation with Melanie Mickelson today.
Oh yeah, I talked with her for about. I could have talked with her longer, but I had a work appointment. But
She told me. We were talking about it's important to groom the next generation. That'd be you, man.
yeah.
So,
Oh, I've got some ideas. So
I'm
Trying
sure
to-
you do. I'm sure you do.
Yeah.
No, we were going back and forth about Anaheim.
yeah,
And the one I had proposed with an author from Canada, a guy by the name of John Waldman, and with Jay Sanlow at University at Milwaukee Medical College.
I know Jay.
Yeah,
Yeah,
I know you do.
yeah,
Yeah, they turned us down. They put something else in its place. So I was a little bit upset, but I'm teaching a course, and so it's not the end of the world.
Yeah.
But this was a male factor thing, and that's what I wanted to have on there. But there,
yeah.
what can I tell you? Anyway.
Yeah.
All right. Well, thank you again, Stephen. I appreciate the opportunity to do this, and you're doing a good job, man.
Thanks, appreciate
All right.
it, and I always learn something from you. So
I'm glad I'm still able to impart knowledge. All right.
Yeah.
Take care. Have a good
yeah,
rest
you
of the
too.
day.
All right,
Okay,
bye.
bye-bye.